Good evening, everybody, and sorry for this slight delay. Today, we have the pleasure of having Dr. Prasad Gourineni with us. As you must be aware, Dr. Prasad works both in Chicago and in Tirupati, where he's recently been involved in the setting up of a excellent orthopedic hospital, and he spends half his time between Chicago and Tirupati. So it's with great pleasure that we welcome Prasad for today's webinar. This is brought to you by the Orthopaedic Research and Education Foundation. And Prasad is an expert on the hip, especially the adolescent and young adult hip. And it will be a pleasure to listen to him talk about analyzing hip dysplasias or problems in the hip. So over to you, Prasad. Thanks.
Thank you, Dr. Mukhopadhaya. I'm sorry for the delay again, guys. No. I'm going to share my screen now.
Perfect.
All good?
Yes, sir.
And my voice is okay, I hope. So
yeah, it's great, sir.
All right.
So very good.
I'm glad to be here. This is one of my favorite topics, discussing radiology of the hip. When you say radiology of the hip, it's radiographic analysis of the morphology. We're not talking about tumors. We're not talking about any pathology here. It's basically the morphology. And I'll mention a few variations of the morphology that can become pathological to cause what's called mechanical pain. Again, we're not talking about AVN, we're not talking about bone marrow edema syndromes, not tumors, not lesions, not fractures. It's normal morphology and variation that we can pick up on plain radiographs. Okay, with that background, we're going to look at X-ray of the hip. So when we say normal morphology, there are various other ways to call the same. Is it the most common type of morphology? Or is it the ideal morphology we're going by? The reason I say this is because if you get X-rays of most of us, some parameters won't be totally ideal and normal, but they're common. So we need to make a distinction as to which ones are morphological variations and which ones are pathological before we treat. Some variations often cause problems like tumors and infection, but some variations like a deep acetabulum, shallow acetabulum, or a cam morphology may not be pathological, but it's important that we identify that there are variations of the ideal morphology. So most variations do not cause problems, but clinically we'll figure out in a different talk some other time which ones are more significant. Now among X-rays, AP pelvis is the most important image. Compared to CT scan, MRI, and any other view, an AP pelvis is the most important image. The reason being, it tells you how the acetabulum is placed in the pelvis. It tells you how the relation between the spine, sacrum, rest of the pelvis is to the acetabulum. The femur does not change a whole lot on the views except for AP and lateral. But a pelvis X-ray is essential to look at how the acetabulum is oriented so that you can call an acetabulum abnormal or a normal. So what's a perfect AP pelvis? In a perfect AP pelvis, you don't want any rotational deformity. So both hips should be nicely aligned with the central sacral line or the spine. You want the feet internally rotated so that you can see the profile of the neck. That's not ideal, but it's a good idea to get the feet internally rotated to look at the full length of the neck. Pelvis also has a parameter called tilt, the anterior tilt. We usually say that it's about, say, 35-40 degrees of anterior tilt. But on an X-ray, to look at what degree tilt is, we look at the distance between the sacrococcygeal junction to the symphysis. The reason we pick sacrococcygeal junction to the symphysis is because SC junction is more clearly seen on X-rays than the tip of the coccyx. So from this SC junction to the symphysis, ideally, about 2 to 3 millimeters of distance is a good X-ray. That means that it's not too much of an inlet or outlet. With an outlet view, the distance will be less, and inlet view it will be a lot more. Then you want the beam centered so that both hips can be seen equally well. And the exposure should show the acetabular walls well. That means the anterior wall and the posterior wall of the acetabulum should be clearly visible on that X-ray. This is a supine X-ray being taken. There's a specific distance, tube to image distance and all that. Those are not as important as entire epipelvis with no obliquity and appropriate, not too much tilt and no rotation when we take the X-ray. And the feet are internally rotated. Some people say that there's a controversy as to, do you get supine or standing X-rays? A standing hip or pelvis X-ray is more important to look for subluxation, like in a dynamic loading in a dysplastic patient, to see if they subluxate more when they put weight on the leg. FAI is more of a phenomenon that happens in flexion of the hip. So it's more of a flexion activity, flexion internal rotation causing impingement. So it's not important to know what dynamically happens when you stand for FAI. The functional position of the pelvis can vary in the same patient when they stand. So personally, I prefer getting a supine X-ray as a standard so that I can control the X-ray better than a standing X-ray, because standing X-ray can change based on how tired they are, how much they lordoze or straighten their back. And a supine X-ray, that's more controlled. What I tell you is either X-ray, the structure of the pelvis can be seen on both as long as the exposure is adequate. So it's not important that you get supine or standing as long as the film is a perfectly made X-ray, AP view. So on the quality of X-ray, we already talked about rotation, look at the obliquity, look at tilt, and look at, is the bone outline visible? See, the rotation, obliquity, and tilt, you can probably adjust in your head if it's not a perfect X-ray, but if you can't see the bony outline, you cannot make any adjustments. You need to repeat the X-ray to get better visualization of the walls of the acetabulum and more bony details. Here's an X-ray of a person, a young person who came for some other problem and asked him to volunteer for a normal AP pelvis X-ray. Looks reasonably good. So on this, you want to assess to see, is this pelvis adequately rotated? You can see that the symphysis is probably slightly right to the center of the sacrum. So slightly right rotated. This foramen looks a little bigger than the other side because this side is internally rotated slightly. Very slight, but there is this variation that you need to pay attention to. The distance between the sacrocoaxial junction to the symphysis is more than the 2 centimeter ideal. So it's a little bit of an inlet view. You can see the foramen again that is smaller than the bigger ones you see normally. So this is a slight inlet, a slightly right rotated X-ray. You see this, you don't have to automatically send them back for a perfect X-ray, but you can make some adjustments mentally as you gain more and more experience. Here's an example of a badly done X-ray where one side of the pelvis is much higher than the other, right? And it's so rotated that you can see this foramen much bigger and this is much smaller. So it's not a good X-ray to really look at the morphology. Though with experience, you can make adjustments. Example on outlet view. The sacrocoaxial junction is minimal. The foramina are very big. This is an outlet view. What the outlet view does is, it shows the posterior wall to be more covering falsely, and it shows that the anterior wall is more deficient falsely. So if you get a perfect view, these walls will change. That's the reason rotation and tilt of the pelvis change the acetabular parameters. Example of inlet view, where the distance is much increased, very narrow foramina. So here, the anterior wall coverage is exaggerated. Posterior wall coverage is underrepresented. There's a crossover sign where the front wall is overcovering the back side. And this is probably created by the inlet view and not a true pathological abnormality. So based on the little background, we start looking at individual structures. Acetabulum is the first one we're going to talk about. It's not that complicated if you divide the acetabulum into looking at the sourceal, anterior wall, and posterior wall. Only 3 things to look at, right? The sourceal is the weight-bearing dome where you have subchondral sclerosis. So it's looking at a dense line going from medial to lateral on the femoral head. The sourceal, when you look at it, look for three parameters. How big is it? The size of the source seal. What's the shape of the source seal? Usually it's concave on top of a convex head. And the size is around 60 degrees of an arc overall, right? I'll show you that in more details. And inclination. Then you look at the anterior wall, then the posterior wall for coverage, and their own details. Keep in mind that a subluxated hip always will have less coverage and is not a true representative of the acetabular depth. So we want to see if we can look at the acetabular morphology a little differently in a subluxated hip by getting an abduction X-ray or something to reduce the head back in place. There are these signs we're going to talk about: ischial spine sign, crossover sign, and teardrop shape. These are indirect signs of abnormality and do not represent pathology on their own. Back to that X-ray of a healthy man. You all know this line. It's called ilioischial line. We look at represent the posterior column of the acetabulum. But here we're going to call it Kohler's line, which is the parameter of the pelvis to which we're going to look at the distance to the center of the femoral head or the medial aspect of the femoral head and call a hip normally placed, medially placed, or laterally placed. The head, the medial border, is within 5 to 10 millimeters of the Kohler's line. It's supposed to be normally placed. If it's less than 5 millimeters, where the head is almost coming close to the Kohler's line, that's called a profunda, a deep acetabulum, right? A medialized hip center. If the head is way lateral, in a non-subluxated head, the head is considered to be lateralized hip joint. If the head crosses the Kohler's line, that's frank protrusio. So anything less than 5 millimeters till the head touches the Kohler's line is called coxa profunda, a deep acetabulum. Once the head touches the Kohler's line or goes medial to it, it becomes protrusio. That's your iliopectineal line. In hip preservation, we don't have a specific importance for this line, for the anterior column. That is one of the walls. If you want to guess that it's a posterior wall, or if you don't know if it's an anterior wall or posterior wall, the way you look at it is, the anterior wall usually has a nice S shape to it, and it goes towards the bottom of the superior pubic ramus. In comparison, the posterior wall is somewhat more vertical and goes to the lateral edge of the ischium. So the posterior wall is more vertical, the anterior wall is more horizontal. The anterior wall has a S shape to it. This notch here is the psoas bursa, psoas fossa, where the iliopsoas lies in the depression. So this goes to the pubic ramus, and the posterior wall goes to the ischium. If you're confused, you start at the bottom and see which line goes from the ischium up and follow that. That's the posterior wall, and which wall goes from the pubic ramus, and that's the anterior wall. And here, the anterior wall is crossing over and going beyond the posterior wall to cover the head. A crossover sign, this is what's called a crossover sign, is always abnormal, right? You don't want the anterior wall to cross over the posterior wall in a normal hip. That's a teardrop. A teardrop, it's not a one structure, but it's a radiographic marking where the lateral border of the U is formed in the acetabular fossa. The medial border is by the Kohler's line. And this teardrop is usually, these two lines don't touch each other. And there's a nice U-shaped thing called the teardrop, right? A narrow teardrop is a sign of coxa profunda, not diagnostic, but just indicates that maybe the acetabulum is deep. And a wide teardrop is more indicative of dysplasia. Again, it's not pathognomonic of dysplasia, but when you look at it, you pay more attention to the coverage to see if it's dysplastic. That's a sourcil. The sourcil is the subchondral bone that's being seen, right? Which is taking load, so it's dense. If you notice here, my line did not go all the way to the corner of this bone because the sclerosis stopped where I stopped the line, and this bone is not intra-articular. This is extra-articular ilium. So you need to make a distinction as to where the sclerosis stops when you draw the sourceal and measure the angle. So this part that's not continuous with the subchondral bone and elevates up a little higher and outside, that's extra-articular iliac bone. When you look at the sourceal, it's concave on a convex head, nicely centered on this weight-bearing line. How do I draw this line? The primary compression trabecula are right there. I don't know if you can see them well or not, but you can imagine them there. The weight-bearing axis is the center of the primary compression trabeculae. This is where the weight-bearing axis, the loads come. So this line to the sourceal, the relationship is important in a way that the sourceal is centered over this nicely, equal amount of sourceal on either side of this weight-bearing axis. It's concave on this convex head, and it's perpendicular. More important is this overall sourceal tilt, which is upsloping, is perpendicular to this weight-bearing axis. If this sourceal is not perpendicular, more upsloping, that creates a translatory force of the head laterally, more size of dysplasia. Occasionally, the sourceal can be negative, where this side is lower than this side. I'll show you an example, where the head wants to migrate more medially. You may think that what's wrong with migrating medially? It should be more contained. But the problem is, this aspect of the acetabulum does not have cartilage, and this side of the head has a fovea and ligamentous teres inside. So this will cause medial loading, which is abnormal, and will cause medial osteoarthritis. So the sourceal should be nicely up tilting by about 10 degrees. Much more than that, 13, 14 degrees is dysplasia. And 0 to negative, it's negative sourceal angle that can lead to medial loading of the femoral head. This is the vertical line. Now we're measuring the sourceal size. So the vertical line from the center of the head, straight up. That's the line connecting the center of the head to the lateral edge of the sourceal. Again, you see that I didn't draw this to the corner here because that's not sclerotic in this part, and that's not participating in weight bearing. So true measurement will be to the edge of the sourceal. This is called the lateral center edge angle. On the lateral aspect, from the center to the edge, center edge angle, or Weiberg's angle, LCE of Weiberg. And this typically is about 25 to 35 degrees or 40 degrees. And more than that is too much, and less than that is too little. So less than 25 is dysplastic, and more than 40 is definitely over coverage of this lateral center edge angle. A less commonly measured angle is a medial center edge angle. Same vertical line, but here we're drawing a line from the center to the medial side. Most people tend to ignore the medial side, but the medial side coverage is also important. If the medial center edge angle is deficient, it's called medial dysplasia. And what medial dysplasia does is, again, makes the head load the non-articular acetabulum, that's the acetabulum fossa. That can cause medial osteoarthritis. Here's an example of a reverse sourceal angle I was mentioning. Vertical line. That's about a 40, 45 degrees, maybe over-covered. But more importantly, look at the sourceal tilt. The sourceal angle is negative. So this head is migrating medial. Look at the space that's very narrow between the Kohler's line and the femoral head. The femoral head is now compressing the ligamentous teres between the head and the floor of the acetabulum fossa. And the teardrop is reversed a little bit, right? The medial fossa is actually medial to the Kohler's line. It's reverse. And if you measure, look at the weight-bearing axis going up. The weight-bearing axis going medial to the sourceal. So it's loading non-articular or a place of the acetabulum that does not have any articular cartilage. So this is going to cause arthritis eventually. Here's a case of dysplasia. Here the head is subluxated, so you can't really quantify the acetabular size because the head is subluxated. You can't look at the coverage. Horizontal line to the medial edge of the sourceal. That's the increased sourceal angle. That's typical of dysplasia. 0 to 10 is normal. This is almost 15, 20 degrees. So more than 13 is clearly dysplastic. That's your LCE. Like I said, the LCE is less, but if the head is reduced back into place, the LCE will be much more. So acetabular dysplasia coverage, LCE is not as small as it looks here. That's a Shuntel's line. Sorry. So Shuntel's line, when you draw a line here, look on the left side, Shuntel's line goes along the inferior border of the head and the neck. So this one smooth arc is called normal Shuntel's arc. A broken Shuntel's line is indicative of some abnormality, and usually it means that the head is subluxated. So it's not matching. The inferior part of the neck is much higher than the inferior border of the superior pubic ramus. So with that, I actually forgot to mention this to you. Let's go back to the walls once more. So the anterior wall ideally should cover about 20% of the head at the center of the neck axis. If you draw a line around the center, the anterior wall should cover about 20% or less. Not less, sorry. 20% is ideal, 15 to 20%. Less than 50% is decreased coverage of the anterior wall, and more than 20% will be increased anterior wall coverage. Similarly, posterior wall should go to the center of the head, right to the center. So if it goes to the center, it's normal coverage. If the posterior wall goes medial to the center of the head, that's decreased posterior wall coverage. And if it's more than 50%, it's increased posterior coverage, right? So with that basics, an ideal establisher should have, the femoral head should have about 80% coverage by the source seal. Even if you don't measure LCE, you can grossly look at the head size and see how much of the head is covered by the source seal. About 80% is ideal. The posterior wall should cover 50%, like I said. The anterior wall should cover 20% of the head, ideally. With that, you'll get good range of motion without impingement, right? People talk about established version. They say 15 to 20 degrees. This is more easily measurable on a total hip rather than a native hip. In a native hip, the version changes from where you measure, from the top to bottom. So a better measure for me is to look at the crossover sign and the wall coverage than actually measuring the actual version of the establisher. The source seal size, like I mentioned again, should be at least 30 degrees medial and 30 degrees lateral. So about a 60-degree arc is ideal. Anything more than that can be over coverage, and anything less than that can be under inadequate source seal size. And again, try to pay attention to a high establisher fossa where the medial side is dysplastic. So medial central jangle is deficient. So they can have a high establisher fossa, and that's a sign of medial dysplasia. Source seal angle ideally is 0 to 10 degrees upsloping. More than 10 is dysplasia, and less than 0, again, is a negative source seal angle. And the source seal shape ideally is concave. That's an ideal establisher. So if you look at the ideal in the center, put the ideal in the center, decreased is dysplastic, decreased coverage of the source seal and anterior wall or posterior wall, right? Decreased C angle of less than 24 degrees, increased anteversion, source seal angle higher than 11 are signs of dysplasia. On this side, if it's more than 90% coverage, and there's more than 36-degree angle as LCE, retroverted establisher, or less than 0 degrees of source seal angle, those fall into the impingement category. This is a young person, open truncated cartilage. The white line represents the anterior wall, and the red line represents the posterior wall. You may look at this and call this a crossover sign. The reason I'm showing you this is because a young person with open triradiate does not have full ossification of the posterior wall. So the posterior wall deficiency you see on this X-ray, the crossover sign, is probably not true. And once they become mature, where the posterior, the triradiate cartilage closes and the posterior wall fully ossifies, the crossover sign will disappear. So a crossover sign in an immature child with open triradiate cartilage is probably a false crossover sign. So keep that in mind. So with those wall coverings, right? I told you about anterior wall when it's undercovered, when we call it undercovered, when we call it normal, and when we call it overcovered. Same parameters posterior wall. If you put them into a grid like this, right, there are 9 types of established. 9 types of established. The reason it's important is each one has a different treatment if you need to treat a problem. Let's go over this in a little more detail. The anterior wall is undercovered and posterior wall is undercovered. That's global dysplasia. Both front and back are deficient, right? The anterior wall is normal and the posterior wall is undercovered. That's posterior dysplasia. The anterior wall is adequate, only posterior deficiency. This is global, this is only posterior. But if the anterior wall is overcovered and the posterior wall is undercovered, that means the sternum is turned backwards. That's true retroversion. Some people use the word retroversion for every crossover sign. That's not correct because the true retroversion is posterior deficiency and anterior overcoverage. You can have a crossover sign with global dysplasia. You can have a crossover sign with posterior dysplasia, but the treatment is different between these 3. So keep that in mind. If you have normal posterior wall and anterior wall is undercovered, that's anterior dysplasia. If both are normal, obviously that's normal. Only one of the 9 combinations. If the anterior wall is overcovered and posterior wall is normal, that's anterior overcoverage. We'll have a crossover sign. The treatment will not be the same. For retroversion, the treatment will be antiversion, while for normal posterior wall and anterior overcoverage, the treatment will be totally different. It will be anterior wall dissection. So you need to make the distinction when you diagnose and treat. The anterior wall is overcovered and the posterior wall is undercovered. That's increased antiversion, more than normal. If the anterior wall is normal and posterior wall is overcovered, that's posterior overcoverage. And then if both are overcovered, anterior and posterior wall, that's profunda and protrusio, a deep established. So again, to summarize, you can see crossover sign with anterior overcoverage and posterior deficiency. That's true retroversion. The treatment will be an antiverting PAO. The anterior overcoverage and posterior wall is normal. You cannot do a rotational osteotomy. You should do anterior rim reduction, so rim trimming, and repair the labrum. Both an anterior and posterior wall are both overcovering. That's called protrusio. And there's an option either to do rim reduction globally or do what's called a reverse PAO, a specialized PAO to decrease global coverage. Both anterior and posterior wall are deficient. That's classic dysplasia. And do a standard PAO, not the reverse PAO, but a standard PAO. So it's very important to differentiate which type of acetabulum there is because it's a different treatment for the different type. Here's an example to drive home. Little bit of inlet view, but ignore that inlet view for right now. Red line is anterior wall. See how it's going to the pubic ramus. And the blue line is to the ischium. And a large crossover sign. This posterior deficiency, anterior coverage, that's true retroversion. The ideal treatment for this is an antiverting PAO. Here's an example of perfect posterior coverage, this blue line. Anterior over coverage, more than the 20% we talked about. This is probably 35, maybe 40% coverage. And here, you cannot rotate the acetabulum. You're going to resect this anterior wall. Here's global over coverage. Anterior and posterior wall are both over covering the head. Here it's global resection or a reverse PAO where you rotate the whole acetabulum inwards, medially, to decrease the coverage. Now, a few little variations to look at. A younger person with a very prominent AIIS may even have had an avulsion fracture because it's more prominent than the opposite side. This is called AIIS prominence or a type 2 AIIS that can cause impingement, subspine impingement. The impingement happens between the spine and the neck of the femur, squeezing the rectus femoris and capsule. So looking at the AIIS is important when somebody has flexion pain, straight flexion pain. Here's another prominent AIIS. Some people call it a double wall sign. Another sign of subspine impingement. Here's prominent avulsion that became ossified. So this is extreme of AIIS impingement. Some people even call it a pelvic rib if it formed de novo without any injury. Now on the femoral side, we look at the femur now. we're drawing a horizontal line from the tip of the trochanter. This tip of the trochanter should be at the level of the center of the head, ideally. If it's above, it's a sign of maybe coxa vara, and if it's below, it's more like a coxa valga. Here's a weight-bearing axis going up. The other parameter to look at is the physeal line, the physeal scar. The physis, though it's closed in adults, there'll be a scar usually you can see, and that gives you a clue as to the shape of the femoral head. So the physeal scar would extends over laterally onto the neck. That's called epiphyseal extension sign, a sign of cam morphology. Here's a prominent epiphyseal extension sign going way onto the neck, and you can see the big bump on top of it. Even if you don't see the bump, if you see this sign, that's a sign of cam that's present in a different plane. Here's your sagging rope sign, a density on the side, which is the outline of the head. So this head is deformed, oval shape, a cam here, and a sagging rope sign saying that the anterior wall is extending onto the neck. That's a sign of an aspherical femoral head. Here's a way to quantify asphericity of the femoral head on the lateral view. Make a perfect circle on the head. The point at which the bone goes out of the circle is alpha point. We can call this alpha point now because we published an article explaining what an alpha point is, where the bone goes out of sphericity. So if you measure an angle between the axis of the neck and to the alpha point, that's called the alpha angle. About 45 is healthy. About 50, up to 50 is probably healthy. More than 55 is definitely cam. Less than that is a narrow neck, but there's no real problem with it as long as the neck is strong enough. So alpha angle of more than 45, 50, more than 50, 55 or more is cam deformity. Look at this head. It looks like a perfectly round head, but look at the epiphyseal extension. That means there's cam morphology right here, right? Here again, epiphyseal extension sign of cam morphology. Here's another, you can see the cam on the AP view, epiphyseal extension sign. On the lateral view, you can see a groove actually from the labrum digging into the neck. That's called an impingement groove or impingement ridge. Here, instead of a ridge, they formed a bump, a reactionary thickening of the bone. Again, a sign of impingement. Again, you can see the epiphyseal extension sign. Alpha angle probably goes up to here. And this whole thing is a cam bump. So one slide to show you the difference between cam and a SCFE. In a cam, there's the epiphyseal extension sign, and the alpha point is covered by articular cartilage. It's epiphyseal. In a SCFE, right, the alpha point, there is bone from the metaphyseal prominence. So they're totally different. Idiopathic cam is different than SCFE because the bone that's at the alpha point is metaphyseal bone, while this is bone that's covered by articular cartilage. Another little variation that may look like a slip to you on initial view, but as you look at it, though there is varus here, the head is not tilted into varus. The angle is not bad at all. That looks really like a SCFE, but again, there is no posterior tilt. So this is a variation of a developmental coxa vara. It's not a true slip. The reason it's important to distinguish it is you can't treat it like a slip by doing an osteotomy at the neck level. This needs an intertrochanteric osteotomy. Going back to again X-ray, we're looking at the parameters now. The total sourceal size is what we're looking at right now. Again, like I said, 30 degrees on either side. So a 60 degree is ideal. And a lot more is a bigger sourceal. So what I'm trying to show you here is, pay attention to where the fovea is. Fovea centralis is a depression where the ligament teres attaches into the head. This fovea should not be in the weight-bearing area. So ideally, the fovea should be well below the medial edge of the sourceal. With the fovea is, so that's the distance of the between the fovea and the sourceal. And this is the healthy cartilage of the head that goes all the way back. So between the blue lines is the total amount of healthy cartilage of the head, and between the yellow lines is the healthy sourceal. And the fovea should not be coming in contact with the weight-bearing dome. Here's an example where the fovea is actually touching the sourcil. That's the real healthy cartilage of the head and the acetabulum that are contacting. And this is most of the head that's outside the acetabulum, because what's called caput valgum, the head is in valgus, where the fovea is high. So some people call this fovea alta, caput valgum or fovea alta, where the ligament teres is getting compressed between the sourcil and the femoral head. It's called foveal impingement. Is an example of a caput valgum, coxa valga, and acetabular dysplasia with subluxation. On the right side, this patient also has a slipped epiphysis. So caput, coxa valga, center of the head is well higher than the tip of the trochanter. Even the neck shaft angle will be high, even when you rotate internally. There's head valgus on the neck called caput valgum. And there's acetabular dysplasia and subluxation. Shunter's line is broken. Here's a rare example of coxa longa, a very long neck. Ideally, the length of the neck is 1 head diameter. Anything longer than that is too long. And then anything shorter than that is more common, called coxa breva. And coxa breva can cause a lot of problems with impingement. Coxa longa can make the neck thick and more prone to a fracture, but I don't think it's pathological otherwise. So on the femoral side, 10 to 20 degrees of anteversion is ideal. Increased anteversion is dysplasia. Decreased anteversion will cause impingement. It's called retroversion. Normal neck shaft angle is ideal. Coxa valga, again, can cause dysplasia. Coxa vera will cause impingement. Caput valgum, again, goes with dysplasia. Caput verum, like in a slip, will cause impingement. The epiphysis should be tilted maybe up to 12 degrees posteriorly in a normal patient. Anterior tilt is dysplasia, and a posterior tilt, like a posterior slip, will cause impingement. CT shows a lot. CT shows the head shape and cam better, so you can get whatever test you need to understand it. It allows measurements in millimeters and square millimeters, but I'm not very familiar with these measurements. I don't use it routinely. It's not important. Here's how a CT can show the cam before and cam post-op. Here's what a CT can do. If you upload a CT into the software, it can show you what happens with motion, collision analysis. So that's where the impingement is happening. And it can mimic post-op changes, tell you how much to resect. So it's a good tool in the beginning. MRI is great more to rule out other lesions like tumors in AVN for me. It does not show bony detail and does not allow me to measure angles like I'm used to. So I use it more for a screening tool to rule out other pathology, but shows labral hypertrophy, labral cysts very well, soft tissues really well. Look at the detail you can get with a good MRI. MRI can show other, like I said, soft tissue like gluteus medius tears, trochanteric bursitis, impingement cyst on MRI, labral tears on MRI. Here's a clear labral tear in the front from impingement, a subtle convexity of the head causing this labral tear. Here's a divot from impingement that you can see on MRI sometimes and even on X-rays and clinically. Here's a divot on MRI from impingement. There is a sign called cliff sign. I'm just showing it for completion's sake. Some people say that if you draw a circle on the head on an AP view, there's bone deficient that's inside the circle, not completely going around the circle. We call it a cliff sign. And people call a cliff sign to be a sign of micro instability. Just keep that in mind if they ask you in the exam. I think it's the last concept I'm going to discuss called fear index. If you have the epiphyseal scar, take the central 1/3 of the facial scar and the sourcil. As long as these are parallel, the other deformities are not as important in causing instability. That means that if these are parallel, that means the head is not going to subluxate. So peer index of being parallel or less than 10 degrees, right, is not worrisome, but more than 10 degrees, there's a sign that the head may become unstable and subluxate laterally. That's all I have. Any questions? Let's discuss.
Thank you. Thank you very much, Prasad. That was really excellent, very clear and concise, and I think it should have made things a lot clearer for everybody who was listening to it. I don't, if there are any questions, please ask them now, because these are opportunities you won't get often.
Yes. So while we are waiting for questions, sir, one thing you have explained in your lecture, few signs like ischial spine sign.
Oh, yeah. Sorry, I didn't show that. So ischial spine, right? You all know what the ischial spine is in the back. On a regular AP view, you're not supposed to see the ischial spine. It's hidden, right? Ischial spine will appear if you have an inlet view. Every inlet view will have an ischial spine. Those of you who do trauma all the time, you know that.
Yeah.
So ischial spine sign on a well-done AP view that's not inlet or rotated. The ischial spine will become prominent again if there is a rotation in the pelvis. Say you get a Jude view, you're going to see the ischial spine on one side very clearly, right? Obviously, the posterior column and the posterior type thing will be visible. So inlet view and Jude view should show the ischial spine, but a normal X-ray should not show the ischial spine. So if you see the ischial spine, look at the quality of the X-ray, and the quality of the X-ray is good, then that's maybe a sign that the acetabulum or the hemipelvis is retroverted. It's an indirect sign. The reason I don't use it routinely is because even with an ischial spine, my walls are covering the head appropriately, where the anterior wall is not over-covering and the posterior wall is not under-covering, then it's not really retroversion, right? Retroversion is when the acetabulum is retroverted, and you can tell that by looking at the wall coverage. The anterior wall is over-covered in the front, the posterior wall is deficient. That's true retroversion, whether there's ischial spine there or not. But again, ischial spine is a good indirect indicator to look for acetabular retroversion.
So, one thing, sir, you have given us two terms, coxa valga and caput valga.
Yes.
So that to differentiate between these two. Yeah.
Correct. So coxa valga is a problem that happens at the neck shaft level, between the neck and the shaft. So intertrochanteric area, base of the neck area, somewhere in that area. So you measure with the neck shaft angle, as you know very well. Caput valgum is the head is actually in valgus relative to the neck axis. So if you draw a line along the facial line, the facial scar on an AP view, the neck shaft, the neck axis and the facial scar should be perpendicular to each other. If there's any deformity, right, valgus tilt or varus tilt, that's abnormal. Varus tilt, we call it as a slipped epiphysis, except for that variant I showed you, the last femur I showed you is adolescent coxa vara, not a true slip, but it looks like a slip. Caput valgum is a growth disturbance where the lateral side does not grow and the medial side grows. It's very common in DDH and some type of AVNs where the head grows into valgus in a growing child. So caput valgum is head tilted into valgus, looks like a valgus slip on the neck axis. And caput varum is when the head is tilted medially. And coxa valga and coxa vara are more distal deformities at the neck shaft level.
Yeah. So Prasad, just from your experience, what are the common hip preservation surgeries that you are having to do over the last few years?
So I think the most common surgery I do now is hip arthroscopy for impingement.
Okay.
Cam morphology, over coverage. Everything looks very subtle, but it is symptomatic. Obviously, these patients are coming to me with symptoms, and I examine them through the non-op treatment and then end up doing an arthroscopic correction. That's the most common thing I do. If you look at India per se, about half the time I'm doing open surgery. And the open surgeries are, again, half of them are for dysplasia, acetabular under coverage and doing a PIO or something like that. And half are for deformities. either septic sequelae, a slipped epiphysis
Okay.
deformity, right, or a Perthes deformity.
Right.
So so-called idiopathic impingement is about 50%. The incidence is quite high in India also, but the reason I don't push it hard in India is because most of them are tolerating the problem quite well.
I know.
They don't
I
really
know
seek treatment, and they're not getting arthritis as soon either. In America, I'm worried about premature arthritis. In India,
yeah,
I'm not as
it's not
worried.
so common, especially in
Right.
the hip. It's not so common as the
Correct.
knee, relatively, if you look at it.
Correct.
Great. Thank
So,
you very much, Prasad. That was excellent. I think, sorry we missed a bit of your bit. I mean, you couldn't start on time, but still, I think you did a great job of clarifying a lot of things, and I'm sure everyone has learned from this. And we look forward to hearing from you again on, I mean, this very sort of interesting area, and which you have obviously done so much work in.
Thank you, John. I'll be glad to be back anytime.
Sure, that's great.
thank you
Thank you
very much,
Sorry
very much.
sir.
again for being
No,
late.
that's fine. Okay. We just were uncertain because we couldn't get through to you otherwise.
Yeah.
And we were about to say, okay, as I was pulling out some talks which I had to see whether I could substitute at the last minute. But then you
Yeah.
came in just in time. Great. Thank you.
Thanks again. Good night.
Great to see you. Yeah. We'll miss you in Guwahati, unfortunately.
Yes. Right.
See you. Okay. Bye.
Bye-bye.
Thank you,
Bye,
sir.
everybody.
Thank you, sir. It was great, sir.
Bye.
Bye.